CPD webinar on clinical decision making. My name is Dr. Sandra Sharp and I'm the Programme Leader for our BSc Nursing Studies. And I really hope that you enjoy and benefit from this clinical decision making CPD session. And I hope it encourages you to consider joining one of our programmes in conjunction with MDIS. So we'll just get started. I'm going to tell you first of all the learning outcomes. You'll see my lovely background here is our university campus in Sighthill in Edinburgh, and that's where I work most of the time, but I do travel to Singapore periodically for delivery of the content and programme management in our BSc nursing programme. So today's learning outcomes around clinical decision making are to help you interpret complex information that you will receive from patients. And then I'd like you to assess the significance and the acuity of the presenting information, signs and symptoms, and then assimilate that information to communicate effectively with medical staff, to allow a differential diagnosis to be made, and then to act with skill and efficiency so that you can deliver good quality care. So the first thing that I want to talk about are the elements in clinical decision making. I'll just go back to my slide, sorry, apologies. So there's 4 elements in clinical decision making, and the first is really to do an assessment of the situation, and that's where we define the problem. Now, patients in hospitals and other healthcare settings are quite complex and they come to us with a clinical problem. And it's really important that we can gather information from the patient and that we can assess the situation to help us define the problem before we make a clinical decision. And then we need to consider the potential responses that we could make to this situation. And I'll talk about these aspects in further detail as we progress through this webinar. Thirdly, we're going to select and implement an appropriate response. Now, you'll know that we often talk about the nursing process where we assess, plan, implement and evaluate. And what I'm talking to you today essentially covers the nursing process, but with that added detail of gathering that information and considering possibilities. And then we're obviously going to re-evaluate and review our outcomes. So we are assessing, we're planning, we're implementing and we're evaluating when we participate in clinical decision making. Now, often nurses have to make clinical decisions in every aspect of their day-to-day care with patients, and they don't all need medical intervention or medical discussion. They can just be a decision that needs to be made in the process of your nursing care. So effective decision making encompasses, firstly, understanding the meaning of signs and symptoms, which is why when we study nursing, we undertake studies in anatomy and physiology and pathophysiology. And you probably will be very skilled at interpreting and understanding the signs and symptoms that your usual group of patients present with. But what happens if someone becomes unexpectedly unwell and it's something that you haven't seen before? Those are occasions that nurses find quite difficult and they're unsure how to make effective clinical decisions. So we're going to understand the meaning of signs and symptoms, and we'll explore that further in the process. We also need to identify the relating body system or organ. what is affected by those signs and symptoms and what does it mean for this patient. So we list potential pathological processes. And just to really illustrate this for you, a person could present to you with shortness of breath. In your routine caregiving, the patient could tell you they are short of breath. Now, there are a number of reasons why people can be short of breath. And we're thinking about the lungs primarily, although not always. So obviously people can be short of breath because of heart failure, can't they? They can be short of breath because they have a respiratory infection. They can be short of breath because perhaps they have some other condition like COPD or asthma. So there are a number of reasons possibly for this pathological process of shortness of breath. And we need to understand which it's most likely to be, and we're going to discover how to do that. So we need to differentiate the patient's presentation, and we need lots of information to help us to do that, to help us understand the most likely cause. And then we are going to evaluate the information that we've gained to inform our decision making. So for example, I'd like you to look at this patient's vital signs, and I'd like you to ask yourself a couple of questions. And the first question is, what is going on here? And the second question is, what else do I need to know to make an effective clinical decision, to make an effective nursing diagnosis of what the problem might be? So you take the patient's observations and their blood pressure is 89 on 57. Now, people will know that that is hypotensive and of concern. Then coupled with a heart rate of 111, so our patient's hypotensive, they're tachycardic, they are not well, and I don't know why. Then when I see that their oxygen saturations are 95, their temperature is 38.5, and their respiratory rate is 23. So I've got some further information to help me. So I know that there's a risk, although the patient's oxygen saturations are normal limits, the rest rates increase. So I'm a bit concerned that something is amiss here. And then I've got this temperature of 38.5. Now, I know as nurses, you're already answering the question in your head, what is going on here? And you're probably already making some decisions about what you think the most likely cause of this presentation is. But you're also thinking on, what else do I need to know? What other questions or information do I need to make an effective decision on the appropriate management of this patient? So for example, this could be straightforward sepsis of a non-respiratory cause. This could be the result of something like pneumonia. It could be something completely different. It could be some post-op complication. We don't have enough information yet to make an effective clinical decision, to make an intervention. So we need to think about the other information that we need to know. So there's 3 elements of information gathering, and that's our first steps in getting ready to make effective clinical decisions. So we need a good history from the patient. That gives us a bit more information about what they were experiencing, how long they've been experiencing these symptoms and signs, and the onset. What other information can we get from that patient history? We need as much information as we possibly can to help us make a wise decision. We will use assessment tools, and we will conduct a physical assessment of the patient. Now, I've already taken those vital signs that we spoke about, but I need to be systematic in my assessment to make sure that I've got all the information that I need. So in taking our history from a patient or engaging in any consultation, we can use a consultation model. So in the UK, we typically use the Calgary-Cambridge model, which was developed here by Silverman, Kurtz and Draper way back in 1998, and it's still used widely in our healthcare system in the UK today, and particularly among medical staff. So the first step in our consultation is we need to initiate the session. And that's when we engage in introductions, we tell the person who we are, what our qualifications are to care for them. So it might be as simple as, hi, I'm Sandra, I'm the registered nurse who's caring for you. And it's really important that we set the scene for what we're about to do. Is it okay if I gather some information from you and undertake some physical assessment? So I'm initiating that in a session. I'm going to gather information in step 2. That's where the patient tells me all about how they're feeling, what their signs and symptoms are, and what it is that's concerning them. I need to be quite skillful in my questioning to gather as much information as possible about these signs and symptoms, any other associated signs and symptoms, and anything in their history that could explain this. Then in the Calgary-Cambridge model, I undertake a physical assessment. We'll talk about that a bit later on in a deal of detail. We're going to provide an explanation to the patient, and we're going to plan our care, and then we're going to close the session, making sure that the patient knows what to expect. So some of the assessment tools that we use in the UK, and they're probably quite widely used worldwide. I know when I've worked in Australia, I've used these tools, and you probably use them too. So we've got the Waterloo, and that's about pressure injury risk, and you probably use that or similar tool in Singapore where you work. You might be using an opiate withdrawal scale. You might be using the MUST, the Malnutrition Universal Screening Tool. You might be using a hospital anxiety and depression scale. You might be using early warning scores, and more about those later. So falls risks assessments, lots of kinds of assessment tools that we use when we first meet a patient and on a regular basis as we care for them. But what is important and absolutely vital and essential when faced with a patient who unexpectedly has a deterioration in their condition, as our patient did when we looked at their vital signs, we need to undertake a systematic assessment. I can't stress how important, vital, essential it is that we undertake a systematic assessment, because it's prioritised and organised in order of what will be fatal first. So we are going to look at the systematic assessment. So we call it an ABCDE assessment, and it comprises these components: airway, breathing, circulation, disability, and exposure. And they are organised in order of priority of what will kill my patient first. So let's have a think about the airway. We're going to look, listen, and feel for that airway. So when I look, I can get some good information right away. Is the airway patent? I can tell that because the patient is talking to me. So that tells me the airway is patent. But I need to look a bit further. Do we have normal symmetrical movement in the chest? Is the trachea to the midline? Is the patient looking like they're having difficulty breathing? Are they distressed or visually choking? So I've got lots of information just within that one look. And then I want to listen. I know their airway's patent because they're talking to me, but is their breathing noisy? Can I hear good airflow from mouth and nose without any additional noises like stridor or wheezing or gurgling? And if that's there, why is that? Can they complete a full sentence when they speak with me to provide my the history? And obviously, is there airflow at the mouth, nose and chest? So I can feel for airflow at the mouth, nose and chest. So my look, listen and feel should be quite detailed. And importantly, if anything is abnormal, I take steps to mitigate that immediately before moving on to my next step of breathing. If the person does not have a patent airway, they cannot live for very long. So I need to make sure that I am maintaining that airway. It might be that I need to use airway maneuvers, head tilt, chin lift. It might be that I need to put the patient in a left lateral position. It might be that I need to use an airway adjunct, but I need to maintain that airway. Of course, some other reasons for airway compromise are not as easily fixed with that. Perhaps there's some swelling and my problem is different. And for example, anaphylaxis might be a cause of an airway problem. And all amount of airway maneuvers are not going to fix that. So I need to be good with my clinical decision making to know what is it that's going to remedy this issue or concern that I have. With breathing, this is the second most important thing, airway and breathing. So interestingly, in the research around early warning scores and medical emergency teams, one of they examined the medical records of patients who'd had a cardiac arrest or an unexpected admission to critical care. And what they found was that although all vital signs gradually became deranged for a period of up to 24 hours and sometimes longer, the first vital sign to change was respiratory rate. So when they examined that, and that's why it takes a lot of prominence. If somebody doesn't have a patent airway, they can't be breathing, and if they are not breathing effectively and efficiently, they are not going to get the oxygen to maintain perfusion to their tissues and organs. So a high or increasing respiratory rate indicates that the patient might deteriorate suddenly. So it's important to look at trends and patterns. So it might be that it's high, but it might be that you're not finding the rest rate concerning, but it has gradually been increasing. Say the patient's rest rate was 20, and then in the next few hours it's 16, it's 18, it's 20. It's gone from 12 to 20 over a period of time. You might not be overly concerned about a rest rate of 20, but increasing is a concern. Then we need to look at the breathing pattern. We want to observe for signs of respiratory distress, use of accessory muscles, abnormal breathing, and then we want to listen for breath sounds. Are we hearing anything that indicates a respiratory problem? Can we hear wheezing, stridor, rattling noises that indicate secretions, or stridor or wheeze that indicates some kind of partial airway obstructions? Remember, we talked about airway being a priority. So if we hear stridor or wheeze, they indicate a partial airway obstruction, and that patient's airway could become compromised quite quickly. For example, in asthma, and that's why I need to get my beta-2 adrenergic receptor in there really quickly. That's why I'm going to give them their salbutamol, their Ventolin, or their ipratropium quite quickly. We can feel for signs of abnormality. For example, if there's some unequal chest expansion, or if the patient's got surgical emphysema, which feels a bit like bubble wrap under the skin, and it crinkles, I guess. Then we've got oxygen sat, so we can measure some things. We know that normal oxygen saturations are between 95 and 98 for a patient who does not have any hypoxic COPD, for example. We can auscultate, but only do that if you're trained to do that, and it should be part of a systematic assessment. If you are not trained, but you can audibly hear something is not right, then you should go and seek another colleague who is trained to auscultate. We need to assess for any sign of pain associated with breathing. We might consider a chest X-ray, particularly if we're concerned about some abnormality. We might consider obtaining an arterial blood gas, which can be helpful in assessing oxygen and acid-base balance. And we might want to think of peak flow. Now, peak flow is the fastest rate that air can be blown out of a patient's lungs. But in asthma, this will be lower than expected. And if someone's acutely unwell and acutely short of breath, peak flow is completely useless. They won't be able to participate in that. And we might need to save it for when we've implemented some medication, some treatment, and then we are at a re-evaluation or reassessment stage. In circulation, now, third thing down, and I know, when you work, if you work in cardiology, you might immediately go to circulation when the patient has a problem. But we need to maintain that systematic rigor, because if someone presents unwell with a range of abnormal vital signs and symptoms outside what we expect in their condition, we need to be systematic, because remember, it's what will kill the patient first. If they don't have a patent airway, if they are not breathing effectively, and then thirdly, if circulation is not working. So we need a vital pump and blood vessels conducting system to convey the blood-rich oxygen around the body. And if that is not working, we will have a problem. So the first thing you can do here is look at the patient's skin colour. Are they flushed? Are they pale? Are they grey? Are they cyanosed? Do they have a rash, which could indicate an allergic reaction? And as I said earlier, can provoke shortness of breath. So we're getting a big picture here. We're looking holistically at this patient to try and determine what their issue and problem is. Feel the patient's peripheries, their hands and feet, to check for peripheral circulation. So we want to feel for the temperature and the skin condition. Are they clammy? Is their skin unduly dry? Are they cold or are they warm? Manually feel for a pulse is really important. Now, we do get information about pulse when we do the vital signs with our equipment, our machine. Even if we just put a pulse oximeter on, we are getting the pulse rate. But it's important to manually feel a pulse, particularly when you've done vitals and the patient's vitals are abnormal. It gives us lots of additional information, which we don't get when we just look at a number on our machine. So it tells us the patient's rate, rhythm, regularity, volume. Is this pulse weak and thready? Is the rhythm regular or not? So it's really important, manually feel the pulse, particularly when the patient is unwell. And when they're hypotensive, you might not be able to physically feel a radial pulse. Now, they say that I think you need a systolic of about 90 to feel a pulse on some patients, and then we just periodically, we move up the body until we get a pulse that we can actually palpate. Blood pressure is important because hypotension might indicate vasodilation, like what we might see in a septic patient. It could indicate heart failure or hemorrhage, whereas hypertension could be the patient's normal, but it could be a compensatory mechanism which might cause vasoconstriction and that tachycardia in an attempt to maintain cardiac output and oxygenation. So both might be a concern to us. Now, capillary refill time, we are going to measure. We are going to obscure blood flow by putting pressure on the nail bed for 5 seconds, and then we're going to release and wait for the colour to return, which is capillary refill, and it should be less than 2 seconds. Prolonged CRT can be due to poor peripheral perfusion. Of course, you can do CRT on the sternum if you are already felt the patient's peripheries and they've got quite poor peripheral circulation and they are quite cold and clammy. So we might want to do a central CRT. In circulation, we can consider baseline bloods. They can be helpful for us when we have that deteriorating patient and we need to make some clinical decisions quite quickly. So baseline blood should always be taken. We should be looking for a full blood count, our renal panel, our liver panel, our CRP, our glucose. We should be looking for some blood tests. Now, moving on, we've got D for disability. And D for disability is not talking about any disabilities the patient may have. What it's actually interested in is the conscious level. So alterations in consciousness come under the D for disability, and obviously they will have a big impact on the patient. If they are unconscious or have an altered conscious level, it does place them at risk of a primary airway problem or a secondary airway problem. If someone is unconscious, they cannot maintain their airway. So we are going to be concerned about D for disability. And we are going to consider the aspects such as a head injury, hypoxia, hypotension, some drugs, sometimes drugs that we give a patient, can cause alterations in the conscious level. So you should use a measuring scale like AVPU is the one we use for the quick measure in this assessment. If appropriate, you might want to use a Glasgow Coma Scale or Glasgow Coma Score. Now, these are really good, particularly if a person's had a head injury, but in the immediate with a deteriorating patient, AVPU is sufficient. And that stands for alert, voice, pain, unresponsive. If our patient is alert, they are responding to us, talking normally, they are A for alert. If the patient only responds to my voice and I need to frequently use my voice to maintain eye opening, then the patient would be responsive to voice. So it might be that I have to keep telling the patient, keep your eyes open, please, talk to me, keep your eyes open. If I have to use my voice frequently to maintain consciousness or eye opening, I'm going to classify them as a V. If they only respond to physical stimulus, pain, then I'm going to put them as a P. If they do not respond to me at all, they are unconscious, they are U, and unresponsive. And that's obviously an immediate concern. Any alteration away from A to VPU is a concern. And as I said, if we think there's a head injury or we want to get some further information, we can do the Glasgow Coma Scale, which looks at eye opening, motor movement and ability to obey commands. Always in D for disability, take a blood glucose level to exclude hypoglycemia or hyperglycemia. These affect conscious level, and any time you are faced with a patient whose conscious level is changing or altering and they are not A for alert, always do blood glucose just to be sure that the problem is not hypo or hyperglycemia. And then finally, in our ATE assessment, we come to E for exposure. Now, in exposure, what I'm going to do is I'm going to expose the patient's body and thoroughly examine them to make sure that nothing is missed. But obviously, I'm going to preserve dignity and prevent heat loss. And I'm interested in trying to get an explanation for their acute deterioration, for these abnormal vital signs. So I need to look at any swelling, any bruises, any wounds, edema, blood loss, any drains, and particularly if they're surgical, if they've got drains, how much is in them, any, for example, infusion devices that may be connected. Could they be explaining a change in conscious level, for example? And say, for example, a change in conscious level, bradypnea and low sats and hypotension. I might be worried that maybe the morphine infusion they're having is going too quick. So do think about medical devices when you think about that as well. So take the full clinical history from the patient. You might want to use the mnemonic AMPL, which stands for allergies. Do they have any medication? What are they on and have they taken it? Past medical history. When did they last eat? Particularly if I'm concerned this might be a surgical case pending, and any events that led up to this presentation. So we can take this information once we've fixed all the issues and concerns we've come across during our AT assessment. For example, we've protected and maintained the airway. We have provided supplemental oxygen at breathing. We have provided, perhaps we've just had to change the patient's position. Did they need to sit up to breathe? Perhaps they were hypotensive and we needed to lie them down with their legs raised. Perhaps they were hypotensive and we needed to give them a fluid challenge. Perhaps they were hypoglycemic and we needed to take steps to mitigate that. So already in our AT assessment, any abnormality that we've come across, we've taken steps and we've carried out some interventions to try and problem solve this immediate problem. So lots of things, common interventions that people would do, as I say, are definitely airway adjuncts, definitely positioning the patient. They might be that we need to give analgesia. It might be that we need to give some supplemental oxygen. It might be that we need to do fluid challenges, or alternatively, perhaps they need some furosemide. It might be that we need to normalise blood sugar. So there's already interventions that can take place and have taken place already. And if you don't have, and you won't most likely have prescribing powers for some of these interventions, it's good to be able to communicate effectively what is happening, what your findings are, and would you like me to prepare a fluid challenge? Would you like me to prepare some furosemide for infusion? So it's helpful to have that information in your head to anticipate what might be prescribed by the prescriber. You can also use A to E in mental health. So I've applied it here physically, and that's where you most commonly see it applied when we are looking at the deteriorating patient. But some of you might work in mental health situations, and somebody might come in acutely distressed, or you might have a routine consultation with your client, and you might be concerned about a deterioration in their mental health. So can you still use the ABCDE acronym to remember how nice and easy it is? So we're going to first of all look at their appearance. Is it neglected? Are they dishevelled? Is their dress inappropriate for the weather or environment? Now that's particularly helpful in cold places like Scotland. If you saw someone who was wearing shorts in the snow, I might be concerned. No shoes in the snow. Behaviour, are they disinhibited? Are they impulsive? Is their behaviour a bit bizarre or aggressive or unpredictable? Or are they quite withdrawn and difficult to engage, difficult to make eye contact, etc. What's their communication like? Is it incoherent? Is it rapid, disconnected, confused, limited? Are they completely uncommunicative? What is their communication like? Then we're going to think about ideation. What kind of ideas are they expressing? Their beliefs, their delusions, are they preoccupied? Have they got different perceptions, hallucinations? So what are their thought processes? What are their emotions like? What kind of emotional state are they in? Are they quite excitable, hyper? Are they euphoric? Are they really sad? Is it quite liable or rapidly changing? So we can use it in mental health. Excuse me. So the next thing we need to do when we have all our information is we need to think about differential diagnosis. Excuse me. So differential diagnosis is where we put together all that information and we can identify a disease from its signs and symptoms. And it is where we label perhaps potential or actual problems that could explain this diagnosis. So for example, I did give you some different causes for shortness of breath earlier on. But let's consider something like chest pain. Now, chest pain, most people are going to think about a cardiac event, a myocardial infarction. But perhaps the person has a musculoskeletal injury, and that might become apparent when I question a bit more and do a bit more assessment. Is the pain on movement? Have they had any injury recently or any sporting activity which could explain it? So could be musculoskeletal, and my questioning and examining can be helpful in determining that. Perhaps it's associated with things like heartburn or other conditions. Perhaps they're burping a lot, it's after food, there's chest pain, could be gastrointestinal. It could be respiratory. Maybe they have a pneumothorax or something like that. So do think about all the potential causes and use your history and use your assessment to make that list and try and identify what you think the most likely cause is. Then when we've done our assessment, we're going to report our concerns to a medical professional. Now, in reporting concerns, as I said, in the UK, we use what we call a National Early Warning Score, or NEWS. And what that does is it provides an effective means of communication, and it also helps nurses to articulate their concerns about a patient. So often what happened in the past, when lots of little vital signs were a little bit abnormal, nothing was acted upon. But now we generate a score cumulatively, and once we have this cumulative score, it gives us a better picture of how unwell this person is. Now, for example, my patient can generate a score 0 to 3. Now, if their respiratory rate is normal limits, they're going to generate a score of 0. However, if it becomes abnormal, either low or fast, we will generate a score. Similarly, with our oxygen saturations, they will score nothing if it's 96 or above, but they will start to score when it drops below that. Are they on supplemental oxygen? Yes or no? What is their temperature? What is their systolic blood pressure? So we're only interested in systolic blood pressure, not diastolic. That doesn't count towards generating an abnormal news score. What is their heart rate? Is it low or fast? And remember, on our AVPU, do they score 3? Anything away from A scores 3. So we have got all our assessment information, and we're able to calculate our news score. And this gives us a reasonable idea of how unwell our patient is. So if they score 0 to 4, that's a low score and suggests that normal clinical monitoring should be continued. And the medical professional, in this case usually a registered nurse, will decide if further clinical care needs to be updated. Now, what I always advise staff to do, nurses to do, is if my patient is generating an abnormal score, I will up and increase the surveillance of that patient. It might be that they've only to have vitals done 3 times a day or 8 hourly. If they are scoring, particularly if that's not normal for them, then I'm going to increase my surveillance, and I might say, well, I'm going to go in another 4 hours. If it's more abnormal, I'm going to go in a bit more frequently. So 5 to 6, a medium score. That suggests that we should get a medical doctor, a medical specialist to review our patient, and that person should have some competencies in acute illness. And it might be that they need to make some kind of referral to critical care, or that they might need to at least alert a senior medic that this person is quite unwell and may deteriorate. So this is your patients when you're doing your safety huddles in the ward and you're in charge of the shift. Always identify these patients to the team, your nursing team, so that they know who needs to be having an eye kept on them. Who do we need to be concerned about? Who might deteriorate and need that crash trolley? So do bear that in mind. Any score of 7 and above indicates that that's a high score and indicates urgent care is needed. So we put out a medical emergency call, and that patient should be reviewed immediately and perhaps transferred to another department for further care. So just to go back here for a moment, it can be quite easy to generate that kind of score. If you think that I just need a respiratory of 24, let's say, and I've already got 2 points, my oxygen saturations are down to 93, which most people would think is not terrible. Respiratory 22, SATs 93, but I've already got a score of 4, so I'm unwell. Now I'm on supplemental oxygen, I've already got a score of 6. So you can see how this early warning score helps us identify patients that we should be worried about and concerned about, and helps us make sound clinical decisions about how frequently we monitor that person and how we communicate our concerns within the team, and what interventions might be appropriate to be administered. Then I'm going to report my concerns to a medical officer using SBAR. Now, I've put an I at the front here, and some people put a D at the end as well, but it's important to introduce yourself, to say who you are when you're making that call. It's Nurse Sandra here in Ward XYZ. I'm calling about a deterioration patient, Mr. Such and Such, who is presented with chest pain and acutely short of breath. He's the patient who was admitted with, let's just say he was admitted with a respiratory infection 2 days ago. Here's the results of my assessment and what my NEWS 2 score is, and could you come and review him is my recommendation. Or would you like me to, and you can also ask, would you like me to undertake any interventions in the meantime? Now, to provide the evidence-based care for this patient, we are going to use our guidelines. Now, this is vitally important. So I'd like you to have a look at your Ministry of Health guidelines for some of the acute conditions that you might encounter in your day-to-day nursing practice. So if your patient becomes acutely unwell with some sudden onset respiratory problem, cardiac problem, or they have a hemorrhage or an anaphylactic reaction, no matter what it is, your Ministry of Health will have guidelines that you can use to provide evidence-based care. Always check and see how we manage a particular patient so that you know the appropriate care, and you can anticipate orders and you can prepare before the order is, or at least prepare the equipment before the order is issued. In the UK, we have NICE guidelines or SIGN guidelines that we use that are both pretty similar. And you might know of some of these guidelines as well, and we use all the guidelines based here when we develop our content throughout our programme and when we do our teaching. What I'd like you to do now is have a think about how you can put this all together, how you can apply this to your daily practice when you go about your daily business. So just to reiterate some of the key learning points that you should think about when you are needing to undertake some clinical decisions, they need to be based on information and evidence. And a systematic assessment of patients is performed so that specific information can be collected and collated to inform patient care. And if something is not within normal parameters, always ask yourself, why is that? And is that to be expected within the condition that the patient presents with and is being treated for? So always have a look at the pathophysiology. So we know that failing to use a structured, systematic method can lead to suboptimal care and can compromise patient safety, which is why it's been brought in. It's just to help people have that systematic approach that they do with muscle memory, A, B, C, D, E. Always use that to assess someone, particularly someone who is deteriorating and you're unexpectedly called into a patient's room because they are unwell. Always use A, B, C, D, E because it's arranged in the order of what will kill the patient. and you should always undertake an intervention that is appropriate at each stage if required. Do report any abnormal findings to another healthcare professional, such as your medical doctor, as soon as possible, and particularly life-threatening conditions. They need to go to medical or senior staff as soon as possible. It might be that you have a smaller concern about an abnormal finding and your nurse in charge might be the appropriate person. Excuse me, I don't know why some of these move on. But do report abnormal information. Hand over the key information from your assessment using that SBAR framework. Nurses like to give a big long story, doctors like headlines. Try and keep your discussion focused to the headlines, the key information that that doctor will need to know to make a decision to come and see the patient and prioritise it, and that intervention is required quickly. Then once your patient is stable, you should assess him or her for any risks. Their condition has changed. What further risk is the patient at? Now that they have lost their conscious level, perhaps they've had a stroke, then we need to think about lots of other things, mobility, malnutrition, Waterloo score, lots of other things we need to think about. Do document any findings in your patient's case notes. And finally, I have some resources that are available for your use. If you click on them, it should take you to the various, well, the ones that are underlined, it should take you to the various papers that you can read. But I'd welcome your participation in our programmes and do thank you for your attention in our webinar here, and hope that you have found this information helpful. And just always do remember that when you are making a clinical decision, it's always based on information. What do I know about that patient's condition by what they tell me, what I can see and measure, and what might be the appropriate intervention in that occasion? So thank you very much for your attention, and I really look forward to seeing you on our BSc nursing programme. So do get in touch with the MDIS staff if you are keen to join our programmes and learn a lot more to advance your nursing career and your knowledge. So thank you for your attention.